Okay, good evening, everyone. Here the NCSI education team comes again with another topic which is very interesting, that is ICU-acquired weakness. There are lots of things there are more dilemmas, like how do we go about the ICU-acquired weakness, especially in our neurological setup where the patients do have neurological weaknesses. This topic we will delve in today, and let's clear our doubt. Let's see which are the red flags and how do we go about it. Once we are aware, we should be able to, go manage this problem more better. So for today's topic, I'm very glad that we have Hemant sir, and he has agreed to moderate this topic with us. And everybody knows about this sir. He is serving as professor, Department of Anesthesia Intensive Care at PGI Chandigarh. And I will request Hemant sir to take the session ahead and introduce our speaker for the day. Over to you, sir.
Thank you very much, Rohini. Good evening, everybody. We have a very relatively new topic, that is ICU-acquired weakness. It's an upcoming concept in a stage of, would say, infancy, where we are trying to understand what weakness related to ICU are, and especially when we talk about in terms of neurological and neurosurgical patients. So to understand the concept, the etiology, pathophysiology, the features, and the various investigations, and how does this ICU-acquired weakness impact the outcome of these patients. So to delve on this, we have a very eloquent speaker with us today. It's Dr. Priya Thapa, who is an assistant professor at All India Institute of Medical Sciences, Nagpur. And Dr. Priya did her MD from GMC Jammu, and she did her DM in neuro-anesthesiology from PGIMER Chandigarh. So Priya, we are very glad to have you over here, and I would now request you to make the presentation.
Thank you for the kind introduction, sir. I'm very glad to be here. Before starting, I would like to extend my gratitude towards the whole NCSI education team, and especially Rohini ma'am and Bharat sir. So today I'll be talking about IC-acquired weakness. We'll start with a case scenario. A 45-year-old female patient with no known comorbidities with coarse facial features enters the emergency with full-blown diabetic ketoacidosis and hypotension. On the day one, she was intubated because of low GCS. On the day one only, her DKA also started improving, but there was dyselectrolytemia which was being managed. On investigating, it was found that she had a large pituitary macroadenoma with apoplexy. As far her management was concerned, it was adequate hydration was being given to her. Euglycemia was targeted using insulin. Also, her basal cortisol levels were low, so hydrocortisone was started. And during her course in ICU, since she had developed sepsis because of a pneumonic patch, antibiotics were also started. By the day 12, her sepsis had improved, her sensorium and metabolic parameters had returned to normal. But she had developed flaccid tetraparesis, which was proximally predominant, and she had global hyporeflexia. Although her cranial nerve examination was normal, but it was very difficult for us to wean her off the ventilator. Further investigations were done, and it was seen that her CSF fluid analysis was normal. Her compound muscle action potential amplitude was decreased. Sensory nerve action potential amplitude was almost normal, and there was decreased excitability on a direct muscle stimulation test. The creatine kinase levels were also increased. Now, since the patient had developed symmetrical flaccid paralysis after developing critical illness, and all the other reasons were ruled out, and also backed with the evidence of electrophysiological findings and increased creatine levels, we made a diagnosis of ICU-acquired weakness. Now, this is a very common scenario which we find in our ICUs, the muscle weakness. Either the patient presents with a primary neuromuscular disorder which triggers the ICU admission, for example, in cases of GBS or myasthenia gravis, or it develops as a secondary disorder when the patient is already fighting a life-threatening disease. Now, this subset of the patients are the ones which get labeled with the tag of having ICU-acquired weaknesses. And this is implicating that the neuromuscular dysfunction has no other plausible etiology other than the critical illness and its treatment. Now we know that whenever a patient who is already admitted in the ICU develops an acute onset weakness, it can have multiple causes, right from any lesion in the brain stem, spinal cord, muscles, peripheral nerves, or even neuromuscular junction. It can also be because of any systemic causes or psychiatric illness. Well, we know that ICU-acquired weakness is essentially a diagnosis of exclusion, so all these differentials need to be ruled out. Talking about the incidence of ICU-acquired weakness, it depends upon the population we are studying, what is the age of the population, gender of the population, what is the primary illness the patients are having, when are we assessing, and also what is the duration of the illness the patients were having. So by and large, the usual prevalence which is found is 26 to 65%, and it can even be higher in patients who are suffering from ARDS. Now the term ICU-acquired weakness, it is a hypernym and it includes many subtypes also, like critical illness polyneuropathy, critical illness neuromyopathy, and critical illness myopathy. Also, there can be certain amount of overlap between the patients having ICU-acquired weakness and the patients who already had an evidence of polyneuropathy or myopathy before the admission to ICU. So the diagnostic criteria which we use for diagnosing ICU-acquired weakness, the patient should have generalized weakness developing after the onset of critical illness. Now there is no clear-cut duration, but usually a duration of 7 days is taken as the general norm. The weakness should be diffuse, symmetric, flaccid, and should not involve the cranial nerves. The MRC sum score should be less than 48 and it should be tested twice and on 2 occasions separated by 24 hours. Either the criteria 1, 2, 3 should be satisfied, or the patient should be dependent on the mechanical ventilation, and also the other probable causes of weakness should be ruled out. Now, ICU-acquired weakness can have some short-term complications like increase in the ICU or hospital mortality, increase in the ICU and hospital length of stay, increase in the hospital cost, days of mechanical ventilation will be increased, chances of extubation failure increase, and even after extubation, the patient might have post-extubation dysphagia or ineffective cough. Also, there are certain long-term complications like the post-ICU mortality is still high in these patients. The chances of discharge to home decrease. The chances of discharge to other hospital or rehabilitation center increases. The physical functioning of the patients is poor, and also the length of stay at the rehabilitation center is also increased. Also, the patients are at risk of developing post-intensive care syndrome, which is nothing but the physical, mental, and cognitive dysfunction which the patients continue to have even long after the discharge from the intensive care unit. Now, talking about the pathophysiology, the pathophysiology of ICU-acquired weakness, it's multifactorial. It can be because of certain electrical alterations leading to the dysfunction in the sodium and the calcium channel, leading to nerve membrane hyperpolarization and muscle membrane inexcitability. Also, it causes certain structural alterations leading to the inflammation and the necrosis of the muscle. Certain microvascular alterations leading to the endoneural and axonal degeneration. Also, metabolic alterations can lead to increased oxidative stress and decrease in the antioxidant levels. Critical illness is usually associated with impaired autophagy and also the inflammation and increase in the reactive oxygen species. These all lead to the damage to the mitochondria and ultimately leading to the energy failure. Now, critical illness polyneuropathy is a symmetric distal sensory motor axonal polyneuropathy which affects the limb and the respiratory muscles as well as sensory and autonomic nerves. Now, for establishing its diagnosis, first of all, the patient should meet the criteria for ICU-acquired weakness, which we have already discussed. The compound muscle action potential amplitude should be decreased. The sensory nerve action potential amplitude should also be decreased. The nerve conduction velocities should be normal, and there should be no decremental response on repetitive nerve stimulation. Coming on to the critical illness myopathy, it is characterized by limb and respiratory muscle weakness with retained sensory function. To diagnose it, again, the patient needs to meet the criteria for ICU-acquired weakness. The sensory nerve action potential amplitudes are normal here as compared to in polyneuropathy where it is decreased. The needle electromyogram will demonstrate short duration, low amplitude motor unit potentials with or without fibrillation potential. And when we do the direct muscle stimulation, it will demonstrate reduced excitability. The muscle histology will also be consistent with the features of myopathy. Now, a number of risk factors have been implicated in the causation of ICU-acquired weakness, which involve both the non-modifiable and the modifiable risk factors. The non-modifiable include older age, female sex, higher severity score, presence of multiple organ failure, prolonged mechanical ventilation, prolonged critical illness, and high lactate level. It's very interesting to see that the pre-morbid obesity has some protective effect against the causation of ICU-acquired weakness. The modifiable risk factors include the presence of hyperglycemia, early institution of parenteral nutrition, prolonged immobility, and institution of certain drugs like vasoactive medications, corticosteroids, neuromuscular blocking agents, certain antibiotics, and sedatives. The other possible risk factors include presence of hypoalbuminemia, hyperosmolarity, and use of vasopressors. The case which we discussed earlier, the risk factors which were present was, yes, she was a female patient, she had developed sepsis, we were giving her corticosteroids, and again she had hyperglycemia. So there were 4 risk factors present in our patient. Now talking individually, in the earlier studies it was found that age was an independent risk factor for the causation of ICU-acquired weakness, but the subsequent studies and even a meta-analysis including 5 studies showed that there was no such association. A heap of studies have been done to evaluate the role of corticosteroids in causation of ICU-acquired weakness, and it has generated a lot of conflicting data, and even our meta-analysis have showed that there is no such association. Again, the studies done for neuromuscular blockers, some studies showed that yes, there is a correlation, some studies denied any correlation, and finally, the recent meta-analysis, which included 5 studies, said that yes, there is a significant association between the both. No, there is no effect of renal replacement therapy on increasing the incidence of ICU-acquired weakness, and aminoglycosides, they are a proven risk factor for ICU-acquired weakness development. Coming on to the nutrition, we know that malnutrition leads to muscle atrophy, impaired muscle function, and delayed weaning. Now, if the parenteral nutrition is instituted during the first week, it will lead to more muscle wasting. And this has been attributed because of the inhibition of autophagy and the macronutrient doses, and also the early institution of the amino acids in the parenteral nutrition. Now, when it comes to how do we assess the ICU-acquired weakness, first and the foremost is the clinical assessment of the patient. So we will look at the location of the weakness, what is the severity, how is it progressing, and also we will see the characteristics of the weakness. Now, if the patients, they are conscious, cooperative, and well-oriented, we can perform certain volitional tests to assess the muscle strength, and it can be applied on both peripheral muscles as well as the respiratory muscles. Now, what about the patients who are not conscious, who are sedated, who are not cooperative? A very common site which we have in neuro-ICU. For such patients, we can perform the non-volitional tests. And last but not the least, we can also perform muscle and nerve biopsy on these patients, but it is too invasive and also it has a lot of complications as well. Now, these non-volitional tests, they are, although they have a benefit of being performed on the patients who are sedated and uncooperative, these Tests are very technically challenging to perform, time consuming, and also they are not very easily available everywhere as well. Now, this clinical assessment also helps us to differentiate the type of weakness the patient is having, whether he's having a polyneuropathy or a myopathy. Although the type of weakness is flaccid in both the myopathies and polyneuropathy, polyneuropathy has more of distal involvement, while myopathy has more of proximal involvement. Muscle atrophy and ventilatory failure can occur in both. This critical illness polyneuropathy is usually associated with decrease in the deep tendon reflexes, and also it is associated with distal sensory loss. Now, a very traditional method to assess the muscle power in the peripheral muscles is using the MRC power scale. So, in which we assess the muscle power for shoulder abduction, elbow flexion, wrist extension, hip flexion, knee extension, and foot dorsiflexion, and we make a sum total of these. So, if the total score is less than 48, it indicates that there is significant weakness, and if it is less than 36, it indicates that the weakness is severe. Even simplified MRC score can be used, which is a 4-grade score, and a total of less than 24 is suggestive of weakness. Now, what is the problem with these testing is that we cannot find the cause of weakness. We cannot differentiate whether it is a polyneuropathy or a myopathy. Also, this testing has a ceiling effect, and the actual differentiation between score 4 and 5 may be very subjective. And most importantly, patients need to be awake and fully cooperative, which is a very difficult scenario for a neuroanesthesiologist. Now, the other way to perform is to check for the grip strength using the hand grip dynamometry, and also we can use handheld dynamometer to assess the strength of muscles like biceps and quadriceps. So, a muscle power of anything less than 11 kgs for males and 7 kgs for females is indicative of weakness. Now, all this said and done, we know that it's very difficult for us to find a patient who can perform all that. So, for patients in neuro-ICU, we have certain easy and very function-based tests which will assess just the physical function in the patients. So, we will just look at whether the patient is able to perform a shoulder flexion, knee extension, how is the patient performing when he's changing from sit to stand position, and the step cadence, and we score it from 0 to 3. Another scoring system which we can use is to assess the functional movement of the patients in the ICU, like rolling, changing of the position from supine to sit, sitting at the edge of bed, sit to stand, and walk. And again, it is assessed from 0 to 7. It helps in diagnosis as well also keeping the track of the weakness. Now, coming on to the respiratory muscles, this is the calculation of maximum inspiratory pressure, and it can be measured even in an intubated patient. Now, if the patient is conscious on support mode of ventilation, we can ask the patient to perform the Mueller's maneuver. But if the patient is sedated, we can give an end expiratory pause of 20 seconds. Now, if our patient is able to generate a negative pressure of more than 30 centimeters of water, it predicts successful extubation and rules out any respiratory muscle weakness. The gold standard to assess the diaphragm muscle function is the measurement of the transdiaphragmatic pressure, represented by PDI, which is the difference between the abdominal and the pleural pressure. However, it is invasive and requires the placement of esophageal and gastric balloons. So, if the patients are generating PDI of more than 80 centimeters in men and 70 centimeters of water in women, it rules out any respiratory muscle weakness. Now, these were all the tests which could be done in awake and cooperative patients. Coming on to the tests which can be performed even in the sedated and non-cooperative patients. First is we measured the transdiaphragmatic pressure in response to the phrenic nerve stimulation. However, again, it is an invasive method and we apply the magnetic stimulation to the phrenic nerve. Now, the pressure generated, if it is less than 10 centimeters of water, it is indicative of presence of diaphragmatic weakness. The other one is to measure the endotracheal tube pressure in response to bilateral phrenic nerve stimulation. Again, it is invasive, and we measure the endotracheal tube pressure in response to phrenic nerve stimulation during the airway occlusion. Now, if the airway pressure is less than 11 centimeter of water, that is indicative of weakness. Now, ICU-acquired weakness presents with muscle atrophy and neuromuscular electrophysiological disorders. But mind it, muscle atrophy can occur even without the presence of ICU-acquired weakness. The electrophysiological changes can be detected as early as 24 to 48 hours following the onset of weakness, and in some cases, it can even precede the clinical onset of weakness. So, if our patient is clinically stable, vitally stable, and fully cooperative, we can go for the full nerve conduction studies. In this, we will do the compound muscle action potential, amplitude, and duration, sensory nerve action potential, amplitude. We will look at the nerve conduction velocities and electromyographic features. Now, what happens if the patient is either hemodynamically unstable or non-cooperative? We just go for single nerve conduction study in which we will measure the compound muscle action potential amplitude from the peroneal nerve and the sensory nerve action potential amplitude from the sural nerve. Now, these electrophysiological tests also help us to differentiate between the polyneuropathy and myopathy. The CMAP amplitude is decreased in both, however, the duration of compound muscle action potential is increased in critical illness myopathy, and the sensory nerve action potential is decreased in polyneuropathy. Plus, when we do the direct muscle stimulation, in myopathy, it will be seen that there will be reduced muscle excitability. When we do a nerve biopsy in polyneuropathy, there will be evidence of primary distal axonal degeneration of sensory nerve fibers, and the muscle biopsy in myopathy will show myofiber atrophy, angulated fibers, necrosis, fatty degeneration, and also loss of thick filaments. Now, these electrophysiological tests are very useful, but again, the diagnostic properties of these electrophysiological screening vary over time. So, this was a very interesting study by Hermans et al. He found that on the day 8th, if the patient is having a normal compound muscle action potential, it has a high negative predictive value. And by day 15th, if the sensory nerve action potential is abnormal, it had a high positive predictive value, and only a reduced compound muscle action potential on the day 8th was associated with a higher 1-year mortality. Now, neuromuscular ultrasound is a very useful, easy to perform, bedside and non-invasive test which can detect muscle atrophy as well as changes in the muscle architecture. Now, what are the parameters which we note? Most commonly used ones are the cross-sectional area and the echo intensity. However, we can also use the parameters of muscle thickness, pronation angle, and the fascicle length. Now, the recent studies have shown that the muscle cross-sectional area decreases and the echogenicity increases with the duration of ICU stay. Now, sarcopenia was associated with many of critically ill patients, and it was seen as a predictor for finding the adverse discharge disposition, length of stay, difficulty in weaning, and increase in mortality, and also the extubation failure. Also, it was seen that the presence of sarcopenia and the incidence of sarcopenia was quite high in certain neurological conditions like stroke and epilepsy. And it was as high as whopping 84% in the patients with spinal cord injury. Now, it has been clear that yes, loss of muscle mass is associated with ICU-acquired weakness, but this neuromuscular ultrasound, the accuracy of diagnosing early ICU-acquired weakness is still low. Now, ventilator-induced diaphragmatic dysfunction, it is another manifestation of ICU-acquired weakness, and it is nothing but loss of diaphragmatic force generating capacity, specifically related to the use of mechanical ventilation. It can occur as early as 24 hours after mechanical ventilation, And longer is the duration of ventilation, greater will be the degree of atrophy and the contractile impairment. Now, one of the parameters which we assess for diaphragmatic function is the diaphragm thickness. For this, we will use a linear probe and we will assess the zone of apposition. Now, zone of apposition is the area on the chest where the abdominal contents reach to the rib cage. So here, on the ultrasound, we will see diaphragm as a triple layer structure, the central non-ecogenic layer, which is sandwiched between two high ecogenic layers, which is the pleura and the peritoneum. And from here, we can calculate the diaphragm thickness, both in end inspiration and end expiration. And from these two values, we can also draw the value of diaphragm thickening fraction. So it has studies have seen that even up to 6% decline in diaphragm thickness have been seen per day during mechanical ventilation. The other parameter which we assess is the diaphragm excursion. For this, we will be using a phased array probe, and just below the costal margin, either in the mid-axillary or in the anterior axillary line, we'll be placing the probe. In the 2D mode, we'll look for this exploration line, which represents the diaphragm, and when we place the M mode over it, it will give us the dynamic detailing of the movement of the anatomical structures. And from here, we can calculate the diaphragm excursion. Again, it has to be calculated during quiet breathing and deep breathing. Now, it has been seen that 80% of the patients who have ICU-acquired weakness have diaphragmatic dysfunction. This was a very interesting study done which used the ultrasound to assess the diaphragm function in the patients with traumatic brain injury. And it was seen that the diaphragm excursion and the thickening fraction both decreased over a period of 7 days, and this decrease was very significant on the 7th day following the traumatic brain injury. Additionally, it was seen that the difference in the weaning rates based on the thickening fraction, although it was not statistically significant, but it was very clinically significant. Now, not just diaphragm, we can use this neuromuscular ultrasound to also assess the other respiratory muscles, like we can assess the parasternal intercostal muscle. Now, it also appears as a triple layer structure, and we have to measure the thickness and the shortening fraction from here. And this was an interesting study which showed that the pressure generating capacity of the diaphragm thickening fraction, and the parasternal thickening fraction similarly predicted the failure of the spontaneous breathing trial. So not just the diaphragm, we can also look for parasternal intercostal muscle. The other ways to assess the diaphragmatic function is by getting in fluoroscopy. It will give us a more dynamic information. In mild to moderate weakness, the diaphragm movement will be reduced or delayed. But in severe weakness, even the paradoxical movement can be there. But again, its use is very limited in the intensive care setting. The other imaging modalities include the CT scan, the MRI, dual energy X-ray absorptiometry, neutron activation analysis, and bioimpedance studies. No doubt these imaging technologies will give us a better idea about the body composition, about the amount of muscle infiltration, lean body mass, everything. But the problem is that, again, it is an expensive thing, technically challenging, and also we have to take the patient who is already sick out of the ICU to get this imaging done. Now, already the diagnosis, establishing a diagnosis of ICU-acquired weakness is a tough nut to crack. But when it comes to a neurological setup, it becomes like a Rubik's Cube. Now, we have additional challenges in the neurological ICU, like what happens when the patient presents with delayed onset weakness in already a post-operative neurosurgical patients. What if the patient was already having a pre-existing deficits? What if the patient presents with a neuromuscular disorder primarily, starts improving, and after the initial recovery, deteriorates again? And also, as we know, that the incidence of dyselectrolytemia and the systemic causes of ICU-acquired weakness is quite high in neurosurgical and neurological ICUs. So how do we differentiate? Coming on to the post-operative cases, a few examples can be supplementary motor area syndrome can present with delayed onset weakness in post-operative patients even as late as days to weeks. There can be development or worsening of hydrocephalus. There can be delayed worsening of spinal cord edema. And literature also has some reports where delayed postoperative spinal epidural hematomas and delayed brain infarctions have occurred 3 to 5 days after the primary insult. Now, talking specifically about the GBS, in which in this study, the muscle ultrasound was used to assess the atrophy rate of the muscles, and it was seen that the atrophy rate was maximum on the day 14th and also on day 14th and on day 7th. The atrophy rate was 100% specific and 100% sensitive as a predictor of prolonged ICU stay. Now, talking about the patients like we have in our neuro-ICUs who are non-cooperative, not even conscious sometimes, and in such patients, along with performing the non-violational test, the other interesting way to assess sarcopenia is to assess the temporal muscle thickness. Now, in this study, it was seen that the temporal muscle thickness had shown a high correlation with muscle strength in healthy individuals and also in patients with various neurological disorders. And hence, it can be used as a surrogate for diagnosing sarcopenia. Now, talking about therapeutic options for ICU-acquired weakness, there is no specific therapy. All we can do is to aggressively treat the underlying condition which leads to ICU admission, try to maintain normoglycemia and appropriate nutritional status, try to institute early enteral feeding and avoid early parenteral feeding. Early mobilization and active and passive exercises can be done in these patients. From the pre-existing literature, it has been advised that the neuromuscular blockers and the corticosteroids should be used at the minimal doses for the shortest period of time. Also, maintaining euglycemia using intensive insulin therapy has shown that it actually decreases both the electrophysiological incidence and the clinical incidence of the ICU-acquired weakness. Now, early mobilization and physiotherapy can improve the outcomes in the patients with ICU-acquired weakness. So, along with the routine physiotherapy, some of the patients which cannot be mobilized at all, the other way is to provide them with neuromuscular electrical stimulation. In this, which we place the electrodes on the skin of the patient and provide electric current to elicit contraction in the targeted muscle. The other way is to perform in-bed cycling, which can be a very safe and feasible option. And also it can be done as an active exercise as well as a passive exercise. The third way is to combine both of these, both in-bed cycling and the neuromuscular electrical stimulation. The other way is to use the table tilts, the dynamic table tilts, the multifunctional positioning devices, robotic mobilizations, and also hydrotherapy can be tried in such patients. The other experimental therapies include the nutritional interventions, which include supplementation with the antioxidant therapy, substitution of glutamine, arginine, nucleotides, omega-3 fatty acids, certain testosterone derivatives, growth hormones, and immunoglobulins. All these experimental therapies have been tried and have given very varied results. Now, whenever we encounter a patient in an ICU in whom we are suspecting ICU-acquired weakness, first of all, we have to interrupt the use of whatever sedative and analgesics we have been giving. Assess if the patient is awake and able to follow instructions. If no, keep the sedatives withheld. If the patient still remains unresponsive, we have to go for the brain imaging, CSF studies, and EEG. Whereas if the patient is awake and is not following your commands, we have to assess for the MRC score. If the MRC score is normal, good, just continue with the physical and occupational therapy and observation. If the total score comes out less than 48 and the pattern of weakness is symmetric, then we have to perform serial examination, physiotherapy and occupational therapy has to be continued. If the weakness improves, continue with the same. If there is no change in the condition, or even if there is deterioration, then we have to move on to the electrophysiological testing. If the pattern of weakness is in favor of focal deficit, again we have to see whether we are suspecting a lesion in the central nervous system, then we have to go for the brain imaging. If we are suspecting something in the peripheral neuromuscular system, then we have to go for electrophysiological testing, in which we will perform the nerve conduction studies, the electromyography, and also we can perform the muscle biopsy. Now, these studies will not only establish the diagnosis of ICU-acquired weakness, but also it will differentiate whether it is a critical illness polyneuropathy or it is a critical illness myopathy. Now, to conclude, ICU-acquired weakness is a significant contributor to ICU-related morbidity and mortality. So, we need to have a high suspicion in those with significant risk factors and difficult weaning. We need to exclude all the mimics of ICU-acquired weaknesses. Traditional methods of muscle strength testing have to be done, but unfortunately, it cannot be applied on sedated patients. So here comes the role of electrophysiological studies and serial ultrasounds, which may help in diagnosing this condition early. And diagnosing it early and instituting early rehabilitation therapy may go a long way in improving the morbidity and mortality of such patients. Thank you for your patient listening. Over to Hemant, sir.
Thank you very much, Priya. That was a very eloquent presentation. You clearly brought out the various aspects of this newly upcoming entity of ICU-acquired weakness. So very well presented, and I hope will be clear to all the listeners. And before we take up the questions, so just to summarize as to what for the viewers, it is important that this is an upcoming entity, and most important thing about this ICU-acquired weakness is to understand it's a diagnosis of exclusion. So whenever you rule out there's no other medical or neurological causes for the weakness, and it is purely attributable to the critical illness, then we put up this diagnosis of ICU-acquired weakness. And Dr. Priya has also made out very clearly there are three important clinical entities: critical illness myopathy, critical illness polyneuropathy, and then there is a combination of these two. The most common of these is the incidence-wise is critical illness myopathy. And she has also delved into the various modifiable and non-modifiable factors which is there, and she has very given already tabulated that. And just to summarize the pathophysiology, so for the to make it more simpler, because the pathophysiological mechanism, as you know, is very complex. So whatever, whenever there is a critical illness, the patient has a lot of patient maybe in sepsis, maybe have various type of electrolyte and fluid imbalance, and there are a lot of other uh, uh, pathophysiological processes going on in the body. The most important of these is the inflammation. And this inflammation, what it does is causes tissue edema. And whenever there is a tissue edema, there is always a very high chances of having tissue ischemia and hypoxia, which leads to energy failure. And once there is a mitochondrial dysfunction, which leads to energy failure, so there is proteolysis, the most important. Once the breakdown of the proteins of the muscles and the nerves, and this is what ultimately contributes to the loss of muscle mass and the loss of muscle functions. So this is the the basic pathophysiology of the ICU-acquired weakness. And as far as the signs and symptoms, you have very clearly elaborated. So what are the clinical features? And the most important you said is the symmetrical, diffuse weakness of the body, and usually sparing of the clinical muscle, that is facial muscles. And one thing to note here is if there is increased tone or there is a proximal sensory loss, so they usually rule out a case of ICU-acquired weakness. So that is also important to remember. And investigations, how to delve into that. So you said there's a functional investigations, and then you have a structural in functions. You said you have nerve conduction velocities, and in structural you can do either in the form of an ultrasonographic assessment, or you can do a muscle biopsy. So Priya, that was very well done. And then you also suggested various methods of how to manage this in an ICU setting, and how to prevent it, and what are the. So the most important thing that is to be understood is, why is this entity important? The most important thing is, this entity is important because it impacts the outcome of the patient. So whenever there is a decreased muscle mass, there is a weakness, and because of various reasons. So most important thing is weaning off from the ventilator. And as you know, the more the duration of you have, the more chance of VAP, the more chance of sepsis, and it improves, and it prevents the improvement of the patient. So there's increased length of hospital stay, the increased ICU stay, and then it impacts the long-term outcome of this patient. So that is why it is important that the outcome gets affected. Now, since this is a neurocritical care forum, so it is very important for us to know that how is the patients who are neurologically infected, whether it's a neurological patient or it is a neurosurgical patients, how does it impact these group of patients? Now, most important or the most challenging thing in this group of patients is that these patients may have pre-existing deficit or weakness, and which could be due to certain, as you already know, it could be a Guillain-Barré syndrome, it could be myasthenia, multiple sclerosis, or the patient may have a acute neurological illness like TBI, subarachnoid hemorrhage. So we have to do a clinical correlation before actually we land up with the diagnosis of ICU-acquired weakness. Another important point of these neurocritical care in the patient is they have prolonged immobilization because of they are unconscious, they have neurological disorders. So this leads to what is known as disuse atrophy by itself. And that is one of the major contributors to the weakness in this group of patients. And then there are a group of patients who are present to you with raised ICP, like patients with traumatic brain injury, subarachnoid hemorrhage, acute neurological rise ICP, and most of the, to reduce the ICP, we use prolonged sedation, and in some centers they use a neuromuscular blocking agents also. And most commonly used is propofol, and which has been implicated for it increases the sodium channel inactivation. It causes sodium channel inactivation and mitochondrial dysfunction, which contributes to the ICU-acquired weakness in turn. And then another important thing to reduce the ICP, we use hyperosmolar agents like hypertonic saline, and then we use mannitol. So anything hyperosmolarity has been found out to be a risk factor for ICU-acquired weakness, especially because they dehydrate the muscles and they cause weakness of these group of muscles. So that is also one of the important factors which contributed in neurological patients. And in my experience, the patients, because they are mostly obtunded and the nutritional requirements may not be met. So one of the surrogate markers of protein deficiency is albumin. And those patients, if you see the hypoalbuminemia, and it has been proven in the literature that those patients who have decreased albumin actually can have increased incidence of the ICU-acquired weakness. So along with neurological disorders, so these can also be a contributing factors. So these are a few of the points which you also have to keep in mind to consider in especially the neurological and neurosurgical population. So I think Dr. Rohini, if there are any questions from the audience.
Yes, sir. I think Dr. Priya, you did a very wonderful job with respect to. We know everybody says, "Oh, this is ICU-acquired weakness." What it is exactly? There are more dilemmas. It's not that straightforward entity, and especially the subtleties with which we can think about how to go about the weakness in the neuro ICU, which remains even further more challenging. The implication of this is, and I think you have really done a fabulous job with respect to how do we assess the pathophysiology and what can be done. So it looks like, and the role of sarcopenia. I would like to know whether the sarcopenia is same. Can we say it is same as ICU acquired weakness, or
Uh, when both sarcopenia and ICU-acquired weakness both actually present with the muscle mass loss, with muscle strength loss. But what actually differs is the context in which we are using this term. No, sarcopenia, it can occur because of age-related muscle loss. It can occur because of malnutrition. It can occur because of certain neuromuscular disorders. But when we are talking about ICU-acquired weakness, we are very specific that whatever strength the muscle is losing, it is losing because of the critical illness the patient is having. Now, there can be some overlap because most of the patients who are diagnosed with ICU-acquired weakness will be having sarcopenia as well. But again, the pretext in which we are using this terminology, that actually makes the difference. And sarcopenia, it is the diagnostic criteria is that there should be muscle mass loss, muscle strength loss, and also the loss of muscle functionality. Whether with the diagnosis of ICU-acquired weakness, we have already discussed all the diagnostic criteria. So
yeah,
it
perfect.
seems that these are very similar terms, but actually they're quite different.
Yeah, we cannot interchange them. They are different. Very well said. So we have seen, you have quoted one study for the sarcopenia. There are a lot of studies which are happening, and people are getting aware that muscle mass loss is a big problem in the ICU, which in turn affect their morbidity, mortality. So can you tell us which is the muscle where is commonly used for monitoring the muscle mass? Like, is there
Uh,
anything?
yes, ma'am. Actually, it depends. Mostly, we are using the peripheral muscle for monitoring. The rectus femoris is the most commonly used. Some studies also use vastus lateralis, and even some studies have used at the level of L3. They look for the muscle mass of psoas muscle. So these are the most commonly used muscles.
Yeah, so it's very important to decide one muscle and see at the same level with the, when we are monitoring. So this is very important
And one
point.
study which I had included, they also saw the temporal muscle mass
Correct.
as a
Yes,
surrogate.
that was very informative. So that's another place where, Hemant, so you please add on whenever you feel like.
Yeah,
So
yeah.
I'm just trying to, see that we have not missed something. So these are important. And then what about you have told about the MRC sum score. You have also spoken about the MRC sum score, the muscle
So
strength when we talk about 4, 5, and 0 to 3. Can you please elaborate a little on this point?
this is the one routine traditional method which we use, and we score the muscle bilaterally, ranging from 0 to 5, and it is the same muscle scoring which we use. Now, if the total score is usually 60, the maximum score. Now, if this sum comes to be less than 48, it is the diagnostic criteria. It falls in the diagnostic criteria of ICU acquired weakness. The second, it tells us that yes, the weakness is significant, and if the total score comes to less than 36, it is indicative that the patient is having severe muscle weakness. The other sum score which I told about was the 4 grade muscle, and it is even a simplified version of this. The problem with this 6 grade was 6 score method was that the inter-rater observability was very high. So I might be saying that this is 5, you might find it as just 4. So to rule out that and to make it even more simpler and to decrease the this agreeability, so they came up with this 4 score method in which we use 0 is for total paralysis. One is if we feel that the patient is loss of strength is more than 50% in that particular group. If the loss of strength is less than 50%, it is 2, and if it is almost normal, it is given as 3. So the total of sum in the same shoulder abduction, elbow flexion, wrist extension, and knee flexion, knee extension, hip flexion, dorsiflexion, all these are checked bilaterally. If the total score in simplified MRC score is also less than 24, then it indicates that the muscle weakness is significant.
Yeah, I
Yeah.
think.
So,
Yes.
Dr. Priya, just for the sake of the some of the residents, it may not be clear how this, the Medical Research Council MRC score of 60 is coming, because we are talking at a 48 and then decrease some of. So, can you just elaborate how this 60, the score of 60 is coming
So we have to check the 6 muscle groups, 6 movements
on each
actually.
side?
on each side. So we
Yes.
have shoulder abduction, this elbow flexion, wrist extension, and for the lower limbs we have hip flexion, knee extension, and the dorsiflexion of the ankle.
So there are 6 on each side. So, and each has a score of
And
5.
it
So
has to be
30 on
checked
each side.
bilaterally.
Yeah,
It has to
30
be
on the other
checked.
side. Yes. So that makes it to 60. So if the score comes to less than 48, so that gives you a diagnosis, a clinical diagnosis of patient having the ICU-acquired weakness. So that becomes important. And
Yes.
one of the most important thing I feel is to understand in an ICU settings, there are two things. One is about the prevention or trying to minimize the ICU acquired weakness. This is I'm just out of my own experience in a neurointensive care setting. First is the role of nutrition, especially the enteral nutrition should be started as early as possible, and especially in terms of supplementation of the proteins. So that is one thing. So if it instituted early and with a good amount, good requirement of the proteins, so this is one thing which in my experience have helped the patient for early weaning and preventing the ICU acquired weakness, number one. And second, the role of physiotherapy, instituting physiotherapy, both the chest and the limb physiotherapists, not only once in a day with the chest physiotherapy in a very in a very periodic manner so as to prevent the VAP in these patients, and secondly is doing a limb physiotherapy so as to you know increase increase the blood circulation in this the muscles and to prevent the disuse atrophy. So these two things in a practical sense are very important in preventing the ICU acquired weakness.
Yes. Absolutely. So, and I think the other important aspect of the ICU acquired weakness is also the ventilator induced diaphragmatic dysfunction. So, I think in the ICU, we have to be very careful and conscious about the changing the higher pressure support to the lesser, going as soon as possible at the earliest opportunity to the assist mode and then to the spontaneous mode. So, I think this is another thing which daily rounds we have to be cautious.
Yeah, emphasize this. This is, I think,
Emphasize.
Dr. Rohini, very important because
Yes.
sometimes you tend to keep ventilating, not
Yes.
consciously, just feeling that the patient is not getting conscious because
Correct.
in neurosurgical settings, especially if we talk about head injuries or, other, mass lesions, you have to make sure that once
We
you
allow
have
them to trigger.
yeah, so
Yes.
how fast you can wean them off, and if the patients are unlikely to wake up to get a tracheostomy done, wean them off the ventilator. So this is also
Correct.
one of the very important factors.
Yeah. So we do have, yeah, so uh, Dr. Sumit is saying very well presented. We do have a question from Dr. Bharat. He says, great presentation. Any comment on the use of anabolic steroids in therapy, as well as the role of early versus late tracheostomy? If you can highlight, Dr. Priya and Hemant sir.
Yes, there have been a few studies which have used this anabolic steroid named oxandrolone, and it was found that yes, it can be of some help. Early versus late tracheostomy, I could not find any literature quoting that, but the complications, as expected, is that early tracheostomy, the chest complications will obviously be less, but again, its effect on ICU acquired weakness, I'm not very sure of if I can quote any literature on that.
Yeah, Priya, I can just take over that. So when you talk about the steroids, anabolic steroids, so it can be a double-edged sword. So in one sense, the anabolic steroid may actually help in membrane stabilization, but they are also known to cause muscle breakdown if used in a prolonged and in a slightly higher doses. And the other propensity is that the steroids can lead to hyperglycemia, which can actually increase the reactive oxygen species and lead to oxidative stress, which also has been into muscle mass. So as of now, there is no very clear literature as to how what anabolic steroids and how much dose. So I think still the jury is out on that, and we still need to understand whether really the anabolic steroids are going to make a difference in preventing or maybe in improving the outcomes of these patients.
Yeah, I think it is more of a potential research question in upcoming days.
Yeah. Yes.
It has been seen in burn and patients, I think mostly. But yeah, there's long way to go with respect to it. There's also, I have come across something like intramuscular pellets of anabolic agents like insulin, like growth factor, because one of the very important mechanism is the insulin resistance and inability to uptake the glucose, and thus, the losing of the muscle mass because of the energy, restricted energy. So that's another potential treatment strategy, which is at the animal level, which has been getting explored. So I think yes, this entity do exist, but there's a lot. One is the consciously we have to prevent by being aware of so many factors, which, as sir has aptly told, exercising at the earliest, nutrition, and not overloading nutrition in the beginning because they are in the catabolic state, so they may not be able to uptake, and slowly increase it over 2 to 3 days, or seeing how the patient is doing. So these are all the conscious effort, or the points which we should be taking care
Yeah.
of.
And the second question with Dr.
Yeah.
Sumit had posed up is early versus, and we have already discussed this, the point that although there is still a debate of the outcomes with early and late tracheostomy, but we do know that if early tracheostomy in obtunded patients do have, although the outcomes may not affect, but they do have a decreased incidence of VAP and decreased incidence of the ventilatory days. So I think
Yes.
that is one of the important points to ponder into.
Yeah, it does reduce the morbidity with respect to the mechanical ventilation, but final outcome we are not very sure whether it
Sure.
will,
Yes.
you know. So yes, I think Dr. Biswas is saying very informative session. Indeed, it was very well presented. I think we have tried to cover most of the points, and yeah, I think with this people will be aware of this entity and will look for it, and ensure that whatever we have discussed will be taken care of. So anything as a last comment would you like to say, Dr. Priya and Dr. Hemant sir?
Yeah, so Dr. Priya has already covered very elaborately, but what we need to understand now, since we already have now tried to understand now, this has to be kept in mind always, that what are the risk factors, especially when we talk about the modifiable risk factors, so it always kept in mind to prevent this ICU weakness. But it is also important that important research institutions need to emphasize and try to understand how this entity can be addressed, and especially when we talk about neurocritical care. So what the overlap between the neurological diseases, the neurological weakness, and the ICU-acquired weakness, how to differentiate, how to understand, and how to treat them, and to prevent and then manage them becomes challenging, especially in terms of neurocritical care. So, with that, if Dr. Priya wants to add anything, so.
No, so you have already summarized it so well.
So yeah, I thank to both the speaker, Dr. Priya, and moderator, Dr. Hemant sir. It was indeed a great session, and the NCSI team is thankful to both of you for accepting. So, and to the audience, of course, for putting up the questions and making it more interesting. And I hope everyone finds this topic useful. So, with this, I think we will take the leave. Yes, thank you once again.
Okay, thank you, Rohini, thank you, Bharat, and the NCSI team, and thank you, Priya, for that excellent presentation.
Thank you, sir. Thank you, ma'am.
Thank you.
Thank you, audience.
Yes.